So it looks like we have quite a few people here ready to join. I'm just going to take the first 4 minutes to kind of talk to you guys about some of the cool things that we have at Archer. I'm sure you have seen, if you've seen any of our webinars before, you should kind of be familiar with some of the things that we have here, but I just want to make sure that we cover some of the cool new things that we've got coming for you. Just to really help you feel like you are completely ready for your exam. So, before we get started, it's kind of nice to kind of go over some of these cool things. So, we have this new thing, it's called the Pass Pro. I've been talking about it for a little bit, but what it is basically all of these different methods that come together to make sure that you feel absolutely ready for your boards exam. And it actually gives you a pass guarantee. However, in order to get that pass guarantee, there are some things that we have to do. We call it the Sure Pass method, and we really recommend that you watch all the topic videos, do a quick review of that on-demand section, attend these live webinars when you have the time, or you can watch them again on Facebook. We also highly, highly recommend repetition and questions. So hitting that Q bank every single day, 25 to 50 questions every day. And that's really preparing you for understanding how to approach exam questions, right? You know the information, but how do you show that you know the information when you're sitting for an exam? The more and more practice you have with ANCC or ANP type questions, the better it's going to be for you to feel confident that day of. Then we really recommend doing those practice exams, at least four practice exams once a week. So that's about 4 weeks of studying. And that would be considered that sure pass method. And when the more you take those exams, the more accurate those exams are going to be at predicting where you are in your readiness to sit for the actual boards day. So I always say make sure that you feel super prepared. Set a date at least a month out from when you decide, your study method and go from there. 4 to 6 weeks is pretty on average what people take to prep for these exams. So that's just kind of a ballpark to give you some information. We do have that free trial of the question bank. So if you want just to kind of understand what it is, go ahead and get to that free trial. It's really great. We will be having our live reviews coming closer to that testing um, kind of season in May and June. So when folks kind of finish their programs, start doing just 100% board prep only, then we will have the live review session, which is a 3-day intensive. We do a high level review of everything that you're going to see on your boards exam, or all topics, I should say, on that boards exam. And then we also have that mentoring or tutoring. So that's individualized. You meet with one of us, one of the instructors with Archer, and then we go through and we create a study plan, and then we meet up and we go over questions, how to address content, wherever it is, whatever it is that you need on an individual level. So, we have these big packages that are available for everyone, and then we kind of break it down a little bit. Okay, some cool things that maybe you do know, maybe you don't know, but if you are starting to be a nurse practitioner, if you are a current nurse practitioner, you know that we have required continuing education hours. We now are able to offer, we have accreditation from ANCC to offer these webinars and other things that will be coming down the pipeline for your continuing education. So super, super important that you stay up to date. Every state has different requirements as to different contact hours you have to do. For example, I am certified in a few different states. And so, like substance use disorder and medications to treat use disorder vary state to state, and you need a certain amount of contact hours for that. So, make sure when you're getting your licensure that you understand exactly what that is. And you can come back to us here at Archer for all of your continuing education needs, as we are currently now accredited to offer that type of thing. So for today's lecture, if you're tuned in via Zoom and you stay with us for more than 80% of today's lecture, you will receive one contact hour. I recommend if you're new that you go ahead and create a folder where you put all of your contact hours every single time right after you finish a webinar, right when you receive that certificate. Go ahead, download it, save it, and put it in a file because when you have to come up for your accreditation 5 years later and they require you to show proof of those things, it's easy when it's all in one folder for your reaccreditation, your ANCC or ANPP. So let's get dive in. So if you are logged in, you should automatically get that. And just to review today's learning objectives, we are here to talk about the GI system. We will be going over anatomy, and then we'll talk about how we approach the first assessment of the GI. We'll use some of those special techniques. We'll talk about the most common pathophysiology that we see in our GI and how we treat them and diagnose them. Throughout this, I'll be asking some questions. We're going to use Slido again. If you're not familiar with that, go ahead, take out your phone. We're going to do a Slido way. It's an anonymous way to kind of answer questions and really participate. Makes my job more fun, makes it more interactive for you all. And we know that if we interact with our presenters, we learn more. So, please, please, please don't be afraid. There's no such thing as a wrong answer, like a bad answer. We are going to learn from those answers. So go ahead and if you haven't already, take out your phone for me and let's go ahead and dive into our Slido. So you can scan this QR code. I'm going to do it with you just to make sure everything's working. Scan that QR code. And then here is our first question. So you can just push join on your phone. And then it just says, where are you joining from? And I am in Denver. I know most of you probably know that if you watch any of our things. Denver, Colorado. Anybody else? Michigan. Awesome. Um, Currently, I have a 9 and 11-year-old, and we're working on the 50 states. So we've been listening to that song over and over. And Michigan it just comes to my mind because it's in the way that they present it in the song is kind of funny. All right, we've got Florida, Tampa. That the 50 states, it's really hard to remember. Connecticut. Connecticut. Now I like want to sing the song. I'm not going to sing it. I've been singing it every morning on the way to school. So, okay, awesome. Well, welcome you guys. The next question. Oh, we have one more person typing. We'll give them a moment to see where they're joining us from. Sometimes we have international folks. Oh, sing it. No, I can't. I can't. I can't. Okay, my voice is terrible. All right, and who do we have with us? Nurses, ADNs, sorry, BSNs, LPNs, practitioners, students. Awesome, some students this morning. Great. All right, and we have a current. Great. So save this for both of you. Save this lecture for your continuing ed. Okay, this is 1 hour. I know you have lots of different things that you can probably do, but I just recertified and man, to try to like track that down, I thought I was doing an okay job of keeping track of certificates, but I just need to be more diligent about the moment I finish it and they send you that certificate. Don't leave it in your email inbox, download it right away because those certificates they do expire through the website. So download it, save it into a file just to make sure you're really good. All right. So it looks like we're really just geared towards NPs today. Wonderful. I'm sure there's other people that are watching that might be nurse practitioners or nurses or nursing students. Welcome to all of you. This is a good review for everybody. We'll get in a little bit more depth when we're talking about prescribing and stuff like that. But that gives you an insight into what the world of nurse practitioners looks like in case you're thinking about joining or going back to school, which I will always recommend. It's really a fun job. And so, okay, without further ado, let's jump in to today's webinar. We are talking about gastroenterology. All right. Like I said, we're going to talk about the overall anatomy. Then we're going to go into just assessment and some of those special techniques. We'll also review some of those most common GI things that we do and how we treat them. All right. So just a quick, brief review here. We are going over all of these different parts. In that gastrointestinal tract, we cover a lot. We really divide our GI system into four quadrants, and that is our map. That is our guide for understanding what lives in that area. So when we're describing in our notes where we're having a finding, we understand and everybody knows left, LUQ, LLQ. Those types of abbreviations help us know exactly where we're talking about and then what lives there. So when we're thinking about that right upper quadrant, we'll start up there. You'll really, here we find that liver and the gallbladder. These guys are responsible for processing toxins, fats, and then they have that stomach nearby that really handles some of that early food digestion. That small intestine is going to expand from that upper quadrant down into the upper quadrants down into that right lower quadrant, and its job is really absorbing nutrients, right? And then it hands off that chyme to the large intestine. In the upper quadrant, we have that pancreas that is going to be really responsible for regulating blood sugar, our spleen, which is really important in immunity in the left upper quadrants. And then when we go to our lower quadrants, we have that sigmoid colon in that left lower quadrant, which is really going to work kind of take more water out of the stool and push that stool down. And then that right lower quadrant, which we all think about right away when we think of somebody in pain, and we think of the right lower quadrant, we think of that appendix. So, what is its role? It's still kind of being discovered. We think it has a lot to do with the immune system. That's kind of what the most latest and greatest in research is telling us. But people seem to do pretty well without it in the event that they had something like an appendicitis and needed to have it removed. All right, so we have just our basics in our anatomy and we have our map. So we have the left upper, the left lower, the right upper, and the left right lower quadrants. And that is how we're going to use just our terminology to determine and describe some of our findings when we're doing an exam. Really important when we're covering the GI exam that we follow a little bit of a different order compared to what we may do in other areas, say the heart, when we can go ahead and just start listening. When we look when we consider the GI exam, we are going to do four main steps. And the steps are, and this is important for boards exam reasons, the four main steps are that we inspect. So we look first at the abdomen, have the patient lay flat, supine. I typically have them bend their knees a little bit to help them feel a little bit more comfortable and in control. And what I'm looking for is any signs of different kinds of movement. Can I actually see some peristalsis happening there? Are there any masses? Is there an umbilical hernia protruding there? Any skin changes that I'm concerned about? Any ascites? Stuff like that. I want to use my eyes first. Next, I'm going to auscultate and I'm listening for bowel sounds in each of those four quadrants and really with the stethoscope and really trying to understand what's going on. So we can characterize what's happening in the abdomen, in the intestines based on what we're hearing, right? So normal bowel sounds are kind of those low pitched gurgling sounds, 2 to 5 per minute. And if we're hearing more of those, we think of hyperactive. If we're hearing less of those, that's hypoactive. And no bowel sound whatsoever is considered an absent bowel sound. And that is pretty serious. If you can't hear any movement in that bowel, where we should be concerned. Okay. Next, we're going to move on to percussion. This is a little bit of a lost art. It's super important and it does give us good information. When we're percussing, essentially what we're doing, and the way I do it, I use my middle finger. You want to make sure that the rest of your palm is not touching their stomach because when you have your entire hand touching the stomach, you're going to actually dampen the sound of what you're getting. So really, you're going to pay close attention that just that finger. Some people do it with their index finger. That's fine, but you put it down flat on the belly, and then you're going to actually hit. So try it on your desk when you do this, and you go over different surfaces. You're going to hear that the sound changes, right? I like to use my example is if you're looking for a stud on the wall, if you have one of those handy stud finders, amazing. If you don't, you can actually percuss to hear the change when you're going over drywall and you get to that stud, a solid thing versus where it's hollow, you're going to hear the change. All right. And that is essentially probably what that sound wave is happening. And I'm guessing it uses sound waves that the stud finder, but what you can do is use your ears and you can do that. Same concept. Now we're going over somebody's abdomen, and depending on what area we're over, if it's fluid filled, air filled, if it's a solid mass and organ, it's going to change the sound of your percussion. Okay. And so when we think of tympani, we're thinking of an air filled structure. What would be an air filled structure in our GI system? The intestines, right? So if we're moving over that intestine and there's air in there, it's going to change. When we hit the liver, it's going to sound more dull because that's a solid mass. Now, if we're moving along what we consider to probably be that large intestine, we're coming down that up from the left upper down to the left lower. And we hear a change. Tympani, tympani, tympani. Now we have some dullness and we go back to tympani. What could that be? Well, it could be a mass, right? Or it is probably a mass. It's a solid something. Is it something like a cancer, or is it something as simple as some like stool? Like we have a big, bulk of stool happening there. When somebody is constipated, you may actually even be able to feel it on somebody depending on their body habitus. In children, I think of something that can be really common if you ever have a kiddo with like encoparesis and they are just full in that left lower quadrant, full of stool, and now we have that sludge that's moving around, kind of a little bit of an obstructed stool area in that lower left lower quadrant. That can be very, very common. I've seen it, multiple times, not every day obviously, but maybe a few times a year I'll have a kiddo with encopresis. And when you do something like percuss, you can tell, and you can give the parents a little bit of feedback like, oh, I can actually hear the difference here, and they like to be able to hear that difference as well. So you can hear that tympani, you can hear that dullness. Really important, don't lose this art, don't bypass this in your exam, because it does give us information. Palpation, also super, super critical. Like I said, you can actually palpate sometimes some sort of constipation or stool in that left lower quadrant. But what we're really looking for as well is any masses. I have a patient who unfortunately had metastatic breast cancer, and she came to me just for a primary care visit. We knew that she had metastatic breast cancer, but I'm doing her abdominal exam, and she said, "Yeah, you can actually feel the masses in her abdomen." She's still doing really well and fighting really hard. Let's hope that fight continues in a strong way. But you could actually feel the masses of the cancer in her abdomen, and she was not a very thin person. But this is something that I want you to get comfortable with, so that when you see abnormal, you know it. So you're going to see normal, 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 and you might be that person who actually can first feel something like a metastasis or a growth that's not normal for somebody to have in their abdomen. And the way we catch abnormal is by doing it on normal people all the time. All right. Then we're looking for guarding. Guarding really is suggestive of some sort of inflammatory process happening. What do I mean by guarding? When I'm thinking of guarding, I'm really thinking about somebody who is protecting their stomach. Okay. They have a process, probably an inflammatory process happening. I think of infection, peritonitis, appendicitis, something happening where we have, um, inflammation happening. And when you try to touch their stomach, they're gonna flinch. They don't want you to do this. This is different than somebody who's ticklish. And so, like I said, doing this palpation and understanding what does it look like for somebody who has a peritonitis versus somebody who has who is just ticklish. And so I use their hands along with my hands to go ahead and understand what it is I'm going to do. Warm up your hands first. My hands are always cold. So make sure you have nice warm hands, and then you can have them put their hands on top of yours and touch their abdomen along with you. If you have their knees flexed, that's going to prevent some of that natural guarding that just occurs when we're going to touch somebody's belly. Give them a little bit of a cue what you're going to be doing, just so they feel good. And like I said, if you have that flinching and that really, it's all clues coming together. It's not just one thing. You're going to see multiple things in a person who has an inflammatory process happening in their abdomen. So using all of these different clues to piece together our story of what we think is happening, right? When we're doing our investigation. That's what I love about this job. I feel like we always get to take these clues. It's maybe we are a little bit of investigators in a different sense, right? We are investigating what is happening in somebody's body, but it's like, you watch any of those like true crime or crime shows, and that's what they're doing. They're piecing together. And that's how I approach when I'm working with patients, asking the right questions, not telling the patient what they're feeling, letting them tell us what they're feeling. And then in our exams, we're going to take these different clues to understand and piece together what story makes the most sense, what diagnosis makes the most sense based on all this information that we're gathering all the time. All right, so just another quick review. We're going to do inspection, then auscultation, percussion, and finally palpation. Why do you think it is that we touch our patient last in this case? What are we hoping to get out of these exam findings? And why is this order of exams so important with our patients during them an abdominal exam? Anybody want to put in the chat? Let's see. Why is it so important that we do? All right. I'm not getting any answers here. That's fine. The reason is that we don't want to affect the bowel sounds, right? If we don't have any bowel sounds, the moment that we start to touch somebody's bowel, we can actually invoke them to start moving a peristalsis just from a little bit of massage. So that is exactly why we want to avoid it. We want to listen first because we want an uninterrupted idea of what the sounds and what kind of movement is happening in those bowels before we potentially start making movement ourselves with our hands. Okay, that's our first little review of our anatomy, our exams, and now we're going to get into some of that pathophysiology that we were talking about. Okay, GERD, what is it? Guys, you're going to see this if you work in primary care, urgent care, emergency room, inpatient. GERD is something that affects a lot of people everywhere all the time. So, something that you should just feel really confident about getting your diagnosis and your treatment and kind of your differential going on, risk factors, modifiable, non modifiable risk factors. What can we do about it? How do we approach it? When do we refer? And what kind of imaging and stuff like that would we do? All right, so GERD, really common, also known as acid reflux, okay? What is it? It's really gastric contents from our stomach that is coming back up into the esophagus due to an inappropriate relaxation of that lower esophageal sphincter or the LES. When we think about that relaxation, we think about risk factors. There's quite a few different risk factors. Here are some of them. So if you're over 50, if you have obesity or pregnancy, I think of that putting additional pressure on that lower esophageal sphincter. If you have a hiatal hernia, smoking puts us at risk. High NSAID use, so ibuprofen, naproxen, we're treating something like a knee pain and we're using naproxen all the time. That may increase our risk for GERD, and then our diet. So, our diets, I would say, can provoke some of these things. They can be a trigger that we often see. So, if you're eating really acidic food, spicy food, sometimes caffeine, alcohol, all of those things can play a role in the development of acid reflux or GERD. And what we think about when we think about folks coming in, what they'll likely tell us is, just these different things like heartburn, regurgitation, some chest pain, right? And one thing we want to make sure that we always rule out, because a lot of people could downplay something similar. Any ideas? What is one thing we want to rule out when we think somebody might, we're suspecting GERD, but what can present similarly? What might the patient think they have? Any ideas? Okay, I think I just enabled the chat. I think it wasn't enabled, but now it should be. Acid reflux, yeah, ulcer, good. What's something else that we might have going on? Think of chest pain. What's one thing I want to not miss? Absolutely, a heart attack and MI. That is something that we need to ask further questions around and make sure. Are there any provoking things? So, if you walk up the stairs, if you do some heavy lifting, if you do anything that causes, you know, some sort of elicits a cardiovascular response and that seems to trigger that heart pain or that chest pain, I start wondering a little bit about angina. So is there, an oxygen deficit occurring in this area? So 100% when you have patients come in, and I would guess if you work in an emergency or urgent care setting, you're going to be trying to differentiate GERD versus MI more often than you think because that's what patients, if it's their first time experiencing GERD and it's that chest pain, that burning sensation, oftentimes it's going to present and it's going to be their biggest fear is that they're having a heart attack. And we have to do our due diligence to be able to say with 100% certainty that there is nothing cardiac related happening. And if you can't say that, we need to be able to prove it. So things like an EKG, troponin, all those different markers that we can use. But if you're in a primary care setting, most primary care settings, you can go ahead and get an EKG. And if they're not currently experiencing the problem, then our EKG could be normal, right? If it is just kind of that provoked angina versus if they have, a history of an MI that you might be able to pick up on an EKG. Our director, Hiva does EKG reviews. So make sure you just look at all of our coming up. I'm not sure when she's doing it again. It's absolutely amazing, super, super helpful. So take a look at that. But some questions in your history that would help differentiate between an MI is, like I said, any provoking factors, anything that you can do that really is going to make that chest pain come on. And, does it happen at night when you're laying down, when you're totally relaxed? Maybe you had a big meal, you're laying down at night, and then you start feeling that feeling. Well, that's a little less concerning, right? But we want to ask things about any radiation. Does it go to up to the jaw or down, or do you have any other pain associated with it, right? So we want to rule out MI. That's the most important thing. Okay, some kind of less obvious things that we see with GERD. So, one thing, cough. I have a patient right now. She has this chronic dry cough. Oh, she just did an EKG review. Okay, awesome. She is amazing, and I love her reviews. So, if you missed it, you can go ahead and watch it online. So, check that out. Okay, so currently I have a patient, chronic cough. She had come to me fairly new. She is a new patient to me, has had this cough for probably 10 years. Pretty severe. Wakes her up at night, interfering with her sleep. Um, no provoking factors that we can think of, doesn't smoke, not on lisinopril, which can cause that kind of cough that we see with associated with lisinopril. Um, and we decided to take two routes. I was like, it could be something as simple as acid reflux. So acid reflux, even though she had no symptoms of acid reflux, it can cause this irritation in the esophagus and also in the larynx and the pharynx and cause a chronic cough and irritation. It can also exacerbate any sort of asthma symptoms. So if somebody is predisposed to asthma and they have this acid coming back up, it can trigger some of that happening. We can also see somebody with a sore throat, um, different types of things where we're not necessarily presenting with the chest pain, with the heartburn that we think of with GERD. So when somebody comes to you and they say, I have this chronic cough, it's been going on, think about it. Okay. The other person that I had, he came to me and he said, I was sent here from my dentist, and that is because he's losing enamel in his mouth on his teeth. And when we have reflux, it's called silent reflux. Reflux, we have acid coming all the way up into our mouth, likely at nighttime when we're laying supine. And that acid comes up and actually starts to erode our tooth enamel. Okay. So with both of those patients, we went ahead and did a PPI trial. I also referred the woman over to pulmonology and gastroenterology at the same time. So we kind of had this dual workup because she'd been suffering so long. I felt like I don't want to put these two things off any longer. It's, this person is really having a hard time with this. So we at pulmonology, they're still in workups to understand if there's something else going on with her lungs. There seems to be something initially, I can't remember exactly what it was that they found off, and so they're going to do a full pulmonology workup. However, with GI, pulmonology agreed. Let's make sure there's nothing going on GI wise. She did have an EGD. That was their first kind of course, which I assumed would be. And they found that she actually had Barrett's esophagus, which we'll talk about here in a little bit, and recommended that we stay chronically on this PPI. It's been too long, too short of a time period to really tell. It's only been a couple of weeks that she's been on the PPI to see if the chronic cough is gone. I haven't followed up quite yet, but I'll keep you posted. So things to just remember: cough, asthma exacerbation, sore throat, dental erosion. Those are kind of those silent GERD symptoms that we can see. So just keep that in mind when we're thinking a little bit more about GERD. Okay, so when we do a physical exam, we might not see too much, right? If you're really good at looking people's teeth, you might find that dental erosion yourself. Personally, I don't think that's my strong suit. Maybe a little bit of epigastric tenderness if there's like some early ulceration or tissue damage that's occurring because of the GERD, but really there's not a true gold standard for diagnosing GERD. So a lot of times we're going to rely on our history taking, asking about their symptoms, making sure there's nothing else going on, right? We can 100% rule out that cardiac etiology. And then we're going to do a little bit of trial and error. We're going to talk a lot about modifiable risk factors. Can we change some of these modifiable risk factors versus the non-modifiable things? Red flag symptoms, something that we would want to get an EGD right away, not wait, is if there was any difficulty or painful swallowing, okay, dysphagia. If they felt full really, really fast, if we had any weight loss or anything like that, you're not going to wait around and do some trials of this and that. You're going to send those folks out, okay? So understanding those red flag signs and symptoms, again, if you think there's any sort of cardiac etiology, you're not going to wait on it. Some of those cardiac things can be, not necessarily you have to send them to emergency room today, but do we need a stress echo and all of those different things worked up? And if so, I try to get people into cardiology right away if I feel like I have, a concern. That might be me picking up the phone, talking to the office, talking to the cardiologist, going over the signs and symptoms, just getting a quick, giving them a little bit of the down and dirty of what's happening with the patient. Is there anything I should be doing right away? Is it okay to wait 3 or 5 days until they can get in to be seen? If you're far away from care, maybe even ordering some of those tests yourselves just to get started on that cardiac workup, depending on your setting, right? Okay. For treatment, like I said, we're going to really differentiate between those modifiable and non-modifiable risk factors. And if there are things that we could consider, let's consider those things first before we're adding medication. If they've already made all of these changes and they're coming to you because they've done all these things and it's still not helpful, then we could jump right into a pharmacologic response. But I always want to help folks with some of these lifestyle changes. So if they are obese, can we help them lose weight? Does that mean a GLP-1? Does that mean phentermine? Does that mean just coaching? It depends on your patient. Have that conversation in a very non-stigmatizing way with folks. Oftentimes, if people are obese, they've heard that over and over and over. And so be really cognizant of how you're bringing up that topic around their weight and what have they tried, and do they want some help with that? Because we have amazing things that are helpful. Smoking cessation. Again, we have pharmacologics to help folks stop smoking. If they've tried and they haven't been able to successfully do it on their own, I do recommend something like a Chantix or nicotine replacement, stuff like that, to try to lower some of those negative effects of actual smoking. Avoiding triggering foods, the eating before bed, stuff like that, we can educate folks around. They may not know these things. So depending on their education level, having the conversation is always important. Don't just push it off. All right, so when we do think that it's time for some pharmacologic agents, we have two different kind of classes of drugs that I like to think about. Think of the H2 blockers and the PPIs. All right, H2 blockers, those are amazing, and we use them very quickly, I think of the ones that end in the ending tidine. So famotidine, cimetidine. Ranitidine is no longer on the market because of, I think, don't quote me on this, maybe a cancer risk associated with it. But these guys work by reducing stomach acid through the blocking of a histamine action, the histamine receptor H2 specifically. These guys work quickly. They're typically within 15 to 30 minutes, you'll see an onset and improvement in symptoms. However, um, how long they last. Their half-life is short. So they provide quick relief, but then it also is as fast as it comes on, it also gets metabolized through our body. And so it may require multiple doses in a day to help. We know that H2 blockers, where else do we have histamine receptors? We have histamine receptors in our brain, right? We use antihistamines. For things like allergies, right? So if we're using something like Benadryl, Benadryl is um uh the early what is the word created earlier medication. So they tend to have more of the CNS side effects. When we give an H2 blocker, these are a little bit more specified to that H2. However, they can have central nervous side effects. So, when we think of elderly patients, we want to be careful using H2 blockers because of those potential, um, blocking of the receptors in the central nervous system, which could cause something like confusion. Um, and when we have somebody elderly person who is confused, then we think of increased risk of falling and breaking something. So H2 blockers in elderly folks, it's not never ever. However, it's not necessarily my first line. There's going to be some conversation before prescribing it because of the risk of the central nervous system effects. All right, PPIs, on the other hand, are going to be more of our go-to for an elderly person. We're going to treat their GERD a little bit more aggressively because they tend to have they're at risk of increased adverse events related to untreated acid reflux. All right, I think of their tissue just breaking down faster. And when our tissue breaks down, we think of ulcers, we think of bleeds. All right, so in an elderly person, my go-to is more of the PPI. I'm going to be aggressive, I'm going to be strong. I'm avoiding that H2 blocker because of the possible central nervous system effects. With the PPI, these are the proton pump inhibitors. They end in prazole. I really recommend writing down that class name, the endings, because that's going to be what helps you. It's very hard to remember Pepcid versus Prevacid. To me, they look very similar and it would be hard. So if I remember that generic name, it's going to give me information on my boards exam when I'm prescribing medications, exactly what is that class of medication, what's its action in the body, which is very, very important because these medications work in different ways. All right. So knowing your endings, really critical. Just in general, I like to use generic names when I'm talking to other providers. However, patients oftentimes will tell you the brand name as they're easier to pronounce. So sometimes I have to say, "Oh, you're on Prevacid. Let me just look up. I can't remember which class of medication that is." I'm happy to tell them I don't remember every single brand to every generic name. It's impossible, I think, unless you're like a savant to be able to remember that stuff. So it's okay to say, "Hey, I just need to look up exactly what class that is." Because as soon as you tell me omeprazole, I know right away that's a PPI. I don't have to think anything more beyond that. Okay, the PPIs, they go ahead and bind continuously. So it's a bind forever. So that is going to come onto that proton pump. It's going to bind there and it's going to stay there until the proton pump is regenerated, right? So it will die off, get reabsorbed, and we will create more proton pumps. So irreversible binding is the word that I'm looking for here. This PPIs cause irreversible binding to that proton pump, and that proton pump is going to go ahead and create that acid into our stomach. This guy is very much preventative in in the prevention of an ulceration if we're concerned about that. And if we already have an ulcer, these guys will help us prevent that or promote the healing of any sort of ulceration that is there. They do take a little bit of time to work. Some people will dose this as an as needed medication. Um, and that's okay. But typically, if we're trying to heal something or prevent something from getting worse, it's going to be a daily dose. And we might not see a huge benefit until about 2 weeks when we've actually kind of shut down a lot of those proton pumps. Okay, so that is a little bit longer to work. A couple of days, probably you should notice something, but the peak efficacy tends to be after about 2 weeks of daily dosing. Um, and then, given that, when we take them off, we can get have a phenomenon that's called rebound acid reflux. So whenever we discontinue a PPI, I like to do a slow taper. So say we're doing 40 milligrams daily, I might cut that down into half to 20 milligrams daily, and then I might go 20 milligrams every other day for a week. I would every week kind of decrease 20 milligrams every other day, 20 milligrams every 3 days, and then you could probably get off. So a taper over the course of 4 to 6 weeks will prevent some of that rebound acid reflux. If you discontinue somebody off of a PPI, you don't give them anything else, they may have some pretty severe symptoms coming in worse than before. We can also use an H2 blocker to help us taper off of a PPI if we need to. Go ahead and just dose a famotidine, twice a day on a regular basis if we need to get off a PPI for testing or something. Okay. Um, if we try lifestyle changes, we try medications and they don't work, that's an area in which we may consider going ahead and referring out. So there's things like the niacin fundoplication. That's a procedure where they go ahead and they just irreversibly reinforce that lower esophageal sphincter, stopping that reflux for good. Other things would be like weight loss surgery, if applicable, or prescribing a GLP-1 if that's something that you're comfortable with. If not, referring to obesity medicine specialist who can help with those things. All right, so a quick practice question. We have a 77-year-old with GERD. What is our first line therapy for this person? 77. We have Pepto-Bismol, we have Tums, Pepcid, Prevacid. So again, we're going to go with those generic names. So the subsalicate and calcium carbonate, famotidine, lansoprazole. What do you think? So go ahead and pull out your phone. Sorry, I have this over here in our um, Slido, so you can participate here. So what do you think? Yeah, lansoprazole. We have one person who said lansoprazole, famotidine. Okay, famotidine. What class is famotidine in? And what class is lansoprazole in? Okay, we have two people saying famotidine. All right, one thing I want to bring attention to when we're reading this question is the age of the patient. Okay, we are given the diagnosis, we're given the age. So when we're thinking about these two things together, what is our first line therapy? Those are the words that I would highlight if I were taking this exam question. Um, so the age, what did we say about elderly patients in GERD? We're going to treat them more aggressively, right? And what did we say about famotidine? This famotidine, so tidine, this is an H2 blocker. Where else do we have histamine receptors that we're worried about? Okay, so in an elderly person, using an H2 blocker, we're worried about some central nervous system effects, some adverse side effects that we could cause by prescribing this. So, like I said, it's a never, but it's not going to be our first line. We are going to treat more aggressively than we would with, an younger person. So we're not going to just hit them with calcium carbonate because that's not a very aggressive treatment, right? That's like an as needed, very, if things aren't looking too bad, we can go ahead and do that. And Pepto-Bismol tends to cause constipation in elderly people. They oftentimes already struggle with that. So we're not going to use that one. And our first line is actually going to be that PPI, so the Prazole. That lansoprazole is our first line for this patient because of their age and the diagnosis that we're given. Okay, so that's like what we have to remember when we're thinking through these questions. And if the person was 47, I think famotidine would be an excellent choice. Okay, but being that this person is a 77-year-old, we're worried about that central nervous system effect. Awesome. All right. So we are going to keep moving on. Now we're going to get into peptic ulcer disease. Peptic ulcer disease is often confused with GERD, and they do share this common denominator, which is gastric acid. So GERD, left untreated, can result in something like a peptic ulcer. All right. So if somebody, for some reason, is overproducing gastric acid, stress, alcohol use, NSAID use, family history, smoking, or H. pylori infection, what can happen is that we actually start getting some mucosal lining erosion happening. So that mucosal lining is really, really protective, right? And when we have too much acid, it can actually start kind of eroding that gastric lining and it can cause things like small intestinal, which would be a duodenal ulcer or a gastric ulcer, oftentimes down in the more of the fundal part of our stomachs here. All right. So when we're differentiating, we really think about kind of the symptoms and how these are going to look in different people. So we want to differentiate between a duodenal versus a gastric ulcer. So duodenal ulcers really are happening right at that the pyloric sphincter. So coming back over here real quick. So we see it right here as the stomach connects to the small intestine. We have our pyloric sphincter right here. That's that guy that's really responsible for keeping our chyme from not going back into the stomach, right? We want food just moving in one direction here, but we can get ulcerations here and we can get ulcerations over here in the stomach. And the way that we differentiate is kind of the way that symptoms present. And this is important as well as we get ready for a board's exam and kind of what our patients are telling us. So, what we can have with a duodenal ulcer is kind of this burning, gnawing pain between the breastbone and the navel, so that epigastric area. It typically gets better after eating or with taking an antacid. All right. Gastric ulcers, on the other hand, they get worse when we eat and they have this really intensified pain about 2 to 3 hours after a meal. Both ulcers may present with symptoms of kind of that dyspeptic, kind of nausea, bloating, feeling full. In more severe cases, we might actually get some weight loss, but we're going to look out for these red flags: bloody stools, bloody vomit, severe abdominal pain. Those things could indicate some sort of bleed or perforation happening in the GI system, and we want to get and address those things very emergently. So just take a quick peek at these two ways to differentiate. Those are important. Okay. Now, when we're doing our physical exam, we said GERD, we don't see a lot, maybe a little bit of epigastric tenderness. Okay, sometimes with GERD. A lot of it we said was in the history, right? When we're thinking now about a peptic ulcer disease, we do see abdominal pain. We do see epigastric tenderness. So when we are doing our palpation, we are going to elicit a little bit of that pain when we push down on that area. More concerns for like a perforation would be really intense epigastric pain, tachycardia, that abdominal rigidity or guarding that we see. And anything like this happening, guys, if you're not in the ED, you want that patient in the ED. Okay, we confirm our gold standard for confirming a peptic ulcer is going to be using an EGD, and that is going in with a camera, seeing it. We can also do things like the barium swallow study for patients who can't undergo that. And then a urea breath test. That guy is looking for the H. pylori enzyme in an exhaled breath. All right, so if the patient has been on a PPI in the last 2 weeks, we cannot get a PPI. It will cause a false negative on that H. pylori. But if I'm suspicious for an ulcer, I'm going to go ahead and get an H. pylori. You're going to ask, what medication have you been taking? Likely they're going to give you the brand name, Prilosec. In that case, we're going to wean them off that Prilosec probably quicker than I would do typically. I'm going to go ahead, hit give them a prescription for famotidine, get them off that Prilosec for at least 2 weeks. They have to have no Prilosec in their body, no omeprazole, no lansoprazole, none of those prazoles in their body for at least 2 weeks to go ahead and do that breath test. We can also consider a stool sample. The serum antigens, not necessarily that recommended, not used that commonly. I would say personally, I use the breath test um, pretty much exclusively, unless somebody's getting an EGD. In that case, they're going to do a biopsy and sample for H. pylori. Um, okay, we can consider some other tests. We could do liver function test, amylase lipase. We're ruling out some sort of liver etiology. We're ruling out some sort of pancreatic etiology. We could get a CBC to see if there's actually some anemia secondary to like a slow upper GI bleed. Okay. And what do we do for treatment? Well, our goals here are really to get rid of the symptoms, to heal up any ulcerations, and prevent something like a bleed or other further complications. So we're going to talk about those modifiable risk factors, right? If they're on an NSAID, can we switch them to something else, or can we just protect their stomach if we're going to give NSAIDs? Same with the corticosteroids. If they're on that, can we discontinue it? If we can't, then we need to be considering using a PPI long term to protect that stomach from that other medication that can be causing it. All right. To treat H. pylori, we have our triple and our quadruple therapies. Quadruple therapy is currently our mainstay, and we're thinking here, treat my belly pain. Okay. When we think of these, we're thinking of tetracycline, metronidazole, bismuth salt, so Pepto-Bismol, and a PPI. You can choose any PPI. I typically choose omeprazole, but pantoprazole is just fine. And then triple therapy, we used to use that. I used to use that when I first started practice. We're no longer using that. We're going straight to that quadruple therapy, as that's what our gastro guidelines tell us to do. So, really a good idea to do this. Both triple and quadruple are going to have two different antibiotics, and they're both going to have that PPI. The quadruple therapy adds a Pepto-Bismol, and the antibiotics change a little bit. So if you can remember these acronyms, treat my belly pain, you can remember tetracycline and metronidazole. And then for the triple therapy, hack that ulcer. Okay, PPI, amoxicillin, clarithromycin. If they have an allergy to amoxicillin or to penicillin, we can go ahead and put in metronidazole in that case. Again, we're going to make sure we have a treatment that we cured them with our treatment. So I do repeat that you're the breath test, but this is the caveat. Now, I've treated them with a PPI likely for about a month of everyday dosing. Okay. So we do the antibiotics. Typically, it's about a 14-day course of antibiotics, of two antibiotics. This is very, very intense. Patients don't often feel really great. And the concern after we do 2 weeks of antibiotics is a C. diff complication, right? So now we've wiped away all of their good bacteria. C. diff kind of comes into role. So something to think about. I love probiotics, or, eating them, taking them, however, getting yogurts. I think, is it, oh my goodness, the Activia seems to be a really like one of the best. I just read an article on it that it actually is one of the best yogurts for a probiotic. So that's something, but if they eat kimchi, if they have any sort of fermented foods, kombucha, anything like that, just to replenish their microbiome after a heavy antibiotic, 2 weeks of heavy antibiotics is always a good idea. And you can go ahead and take those along with the antibiotic therapy to try to maintain that microbiome. And then prolonged. But that PPI is going to be on board for about a month of daily use. And then, like I told you, if we just discontinue that PPI one day to the next, we worry about the complication of that rebound acid reflux. So typically, what I'll do with that PPI is go ahead and do a slow taper over the course of like another 4 to 6 weeks. And now we're looking about 10 weeks, 8 to 10 weeks after treatment. That's when I'm going to get that repeat test of cure for the urea breath test for the H. pylori. If I was unsuccessful, then I may refer out to GI for some help. All right, let's do another practice question here, guys. You can pull up your phones one more time. Okay, let me get it ready here and we'll go to the next question. All right, recently hospitalized for a perforated peptic ulcer. Oh no. reports frequent use of over-the-counter medications for osteoarthritis in his right knee. What pain medication may cause an gastrointestinal perforation? So when we are thinking of, folks take over-the-counter pain medications at high doses more often than you think. All right, one person said ibuprofen. Do we have anybody out there who also wants to give this a try? Two said ibuprofen. Great. Yes, it's ibuprofen. Ibuprofen is an NSAID. NSAIDs seem to break down some of that protective lining, really interferes with our ability to keep ourselves healthy from that. So really, really important. If you are prescribing long-term use of any sort of NSAID, you need to go ahead and prescribe a PPI along with it, especially in elderly patients. They're at more risk. Um, Capsaicin is topical. Topical lidocaine doesn't have any impact. Acetaminophen doesn't seem to have too much bother on our GI system other than the liver. Okay. Okay, so that is it. All right, if you guys, just a quick recap of some of those cool things if you weren't here before. If you're finding any of these questions helpful or difficult, go ahead, get into our free trial of that Q bank. And if you're already sure, go ahead, become a SurePass member, guys. This is really going to help you be really successful. And again, join our community. We love hearing, and this is the way that we can really grow our community of nurse practitioners, students, and then maybe when you graduate, stay in touch. We, as nurse practitioners, need to really support each other and answer questions as we're moving through clinical stuff. So really, really cool. Check out what we have. All right, we're going to move on to some more acute things. Those things that we see often, and then we have IBS and IBD and some hepatitis. So that's what we're going to dive into now. So gastroenteritis, known as the stomach flu, a little bit of a misnomer. I think people use that all the time. I have the stomach flu. It's not influenza. Although influenza, and mostly in children, can cause some GI upset, influenza typically in adults doesn't have too much of a GI effect. All right, so inflammation of the GI system, often triggered by like a viral, bacterial, or protozoal infection. We can get these infections in different means through contaminated food or water. They are mostly very, we consider these to be really highly contagious, spread very rapidly. If you're in close contact with somebody who's infected, you're just at risk. All right, so viral gastroenteritis. If you guys have kids, if you work with kids, you have heard of norovirus and then rotavirus. Rotavirus, we now have a vaccine for. I think they're working on a vaccine for norovirus. I haven't heard where it's at lately, but I felt like it was a kind of a topic when it was kind of everywhere. There's a season for it. It seems to just like every, in the winter, norovirus kind of comes through and it blows an ugly road ahead and makes people feel pretty miserable. These viral gastroenteritis infections are typically very highly contagious. We see folks have complaints of abdominal pain, that watery diarrhea, and vomiting. Both ends, both times. I had a friend who had a Super Bowl party. Her kiddo, morning of the Super Bowl party, started throwing up. Didn't cancel the party, invited a lot of people over. I didn't go because I was actually working a shift, but my husband and my kids went, and 17 people from this party, all within 2 days, about 48 hours. So Tuesday, the party was on Sunday, it was Super Bowl. Party on Tuesday. I had the day off. I was taking my kids to the zoo when they were little, and I was tying my son's shoe. And next thing I know, I have puke all over me. That is viral gastroenteritis. It comes on quick, fast, hard. And then, obviously our day was ruined. We were at home, and that was like so much exposure. I also got it. So did my daughter. Somehow my husband avoided it. He has a stomach of steel. He's from Latin America. I don't know. He's just like never gets sick. But yes, terrible. Bacterial food, on the other hand, I think of more like Salmonella, E. coli. This is coming in our food. There's like one of the fast food restaurants, has this, or it comes in like the spinach because maybe a cow has transmitted. It's a fecal oral kind of transmission here. I also think of camping, some infected water, C. diff. We can have Clostridium difficile in our GI system, but we gave a bunch of antibiotics. So now we have this, imbalance of our good bacteria taking care of those bad bacteria, and C. diff kind of just proliferates and causes really intense bloody diarrhea, cramping, really sick. Typically, they're going to have some systemic symptoms, fevers, chills, body aches, just feel terrible. And that's how we kind of can differentiate that bacterial to viral. Again, we're going to be asking lots of history questions. Next up is protozoa. I think of people out camping. I think of people getting into water that's not necessarily that great. So, Giardia, flagella, these guys cause more of that like really, intense cramping, vomiting, diarrhea. I think of sulfur when I think of Giardia, typically causes kind of that gas that has that sulfuric kind of unpleasant odor. And that kind of leads me more toward protozoal. But again, history is what we're going to be asking for. So recent travel, food history, sick contacts. Were you at a Super Bowl party with all these people and everybody else is also sick? Likely viral. Okay. But we can't, and it happens within that 48 hours of exposure. That window is very, very, telltale. And then we think of the onset, duration, frequency of symptoms. Are you having more than 6 loose stools a day? Then we start getting concerned about dehydration. When we're thinking about, these things, a lot of the cases are self-limiting, meaning they're going to work through themselves, and most people will be just fine. However, we need to make sure that they are able to stay hydrated and that they have support, right? If they're an elderly person and they're at home and they're vomiting and having diarrhea. And yeah, it's probably, we will think it's norovirus, but that person doesn't have the care that is going to be needed to help them make sure that they're able to kind of manage this on their own. All right. So that person you might consider admitting if you were worried about their ability to care for themselves and they're living alone. However, if you have, like me, I had my kids at home and pretty, have the wherewithal to make sure that they're doing okay. And then 2 days later, I had to take care of myself. Um, but I could manage that, right? So looking for signs of dehydration, I look in the oral cavity and kiddos. I think of dehydration a lot of times in kiddos and elderly patients. Typically, if you're a healthy adult, your immune system's intact, you're going to be okay. You're going to get through this, but you just need to make sure that you're, staying hydrated, eating a bland diet, eating what you can tolerate, give your kids what they'll take. Some people really love those replenishing, rehydration solutions like Pedialyte. Fine. Yep. If they like it, they'll take it. Go ahead. You can do that. There's also tons of recipes online for oral rehydration solutions that you can make at home, which are just pretty easy to do. When we were down in Peru, we did a bunch of work around that and how to do at-home oral rehydration. It's actually probably healthier than some of the things that you buy in the store, like a Gatorade or something like that. So you can make these things at home, salt, sugar, and then like add some juice to it to kind of help get those electrolyte balances back up. Very, very easy. But again, oral cavity, heart rate can go up, blood pressure can go down. Those are later signs. Skin turgor, later sign. All of those things we consider. All right. If we think that there's a bacterial or protozoal thing, then we're going to start looking towards those antibiotics, antifungal protozoal infections. So metronidazole is the flagell, um, or something like a macrolide fluoroquinolone, so a Z-Pak or Cipro, common for like that traveler's diarrhea. So you might have patients who come in and say, "Hey, I'm going, to wherever, and I've had diarrhea there before. Is there any way I can get a Z-Pak?" Yes, but wait like 2 days before you take it because it might just be a viral infection. Okay. I really like the Carnet's test. This is a special exam technique that I just like to tell folks about because it can help you differentiate between abdominal wall pain, which could be musculoskeletal etiology, versus visceral pain. And visceral pain, I think of the organs, I think of peritonitis, peritoneal inflammation happening. All right, so how do we perform the Carnet's test? What I have people do is go ahead, lay supine, flex the knees, and you're going to figure out where is the pain. And you're going to put your hand where the pain is, okay? You're going to put some pressure down in that area. Now we're going to ask the patient to engage that abdominal wall. When they engage their abdominal wall, now they have, they do a little bit of like a half sit up. When we engage our abdominal wall, we are protecting everything that lives underneath the abdominal wall. So that is why we have that guarding reflex, right? We're getting ready to touch somebody, they guard, they engage those abdominal walls, and it protects whatever lives underneath that area. So let's say it's the appendix, right? So we have their their body here, or let's go to the left lower quadrant here. So if we're like, is this person constipated? Did this person pull a muscle during a workout or shoveling snow? Or do they have something like diverticulitis? This is a great way to use, this is a great little test. Again, not going to tell us for sure, but it's a clue in our investigation. Based on all the other information we're gathering, this is just one more piece of information that can help us go this way or that way. Okay. So you have them engage their abdominal wall, you're putting pressure on that. If that pain gets worse while you're engaging that abdominal wall, now we think that muscle seems like it's sore. That abdominal wall itself is having an issue. Okay. If that pain gets better when they protect whatever's under there, and I'm pushing on it, and they now have protection, then I think that whatever is causing that pain is something visceral, something that lives underneath the abdominal wall. Does that make sense? So when we think about if we engage that abdominal wall, we're protecting that organ that's underneath of it. If the pain gets worse, then we think it's coming from the wall itself. If the pain with the protection of that, if that flex is better, then we think, well, we're no longer putting pressure on whatever's inflamed underneath the wall. Okay. All right. So, what could it be? We think of cholecystitis, the gallbladder, inflammation happening there. We could have stones. What we think about these folks come in. Your most typical patient, again, it can happen in anybody, but our most typical seems to be females over 40. Pregnancy can do this. Rapid weight loss. Is somebody on a GLP-1? Did they lose a bunch of weight? Did they just have a bariatric surgery? If so, cholecystitis is something that should be on your differential. All right, symptoms, right upper quadrant pain can actually radiate to that scapula area, okay? Worse with eating, nausea, bloating, diarrhea, or sorry, nausea, vomiting, fevers, chills, just feels pretty sick. And it can come and go, right? If there's a stone that's blocking it after we eat, when we expect that gallbladder to do its job and release some of that bile, and it doesn't because it's blocked, then it can get some inflammation and it feels uncomfortable. That's when we can start to see these signs coming up. That's your gallbladder attack. All right, we consider we do a special technique, which is called the Murphy's sign. Okay. Murphy, I think of mid-clavicular. So that's how I remember this. And that's the gallbladder. So Murphy's mid-clavicular line right down into our gallbladder. When we perform this test, we're going to have them take a deep breath in, and we're going to, while they're breathing in and they're allowing us into that cavity, we're going to put pressure on that gallbladder. And if it hurts, if they, they stop breathing in because, oh, now you've touched my inflamed gallbladder, we're going to say, I'm a little bit worried about that gallbladder. What else am I going to do? I'm going to consider getting some imaging, getting some labs. All right, CBC, we might see that white count elevated, that CMP, maybe some liver involvement going up a little bit. We can do an ultrasound, and the HITA scan is particularly looking for that inflammation in the gallbladder, especially any sort of obstruction or inflammation that may be happening there. All right. Next up, we have pancreatitis. Pancreatitis, I think of um, oh, sorry, with the gallbladder, our treatment here, we may as far as treating somebody with this, we might do something like a bile acid medication reducer, like ursodiol. We'll talk about low fat, kind of depending on how they are. We might even be able to get away with that shockwave lithotripsy to break up any stones that might be in there. And depending on their presentation, they may be a candidate for gallbladder removal, which is cholecystectomy. Okay. And that's if it's severe or recurrent, then we might just say, hey, we need to take the gallbladder out. Okay. Sorry, I just didn't talk about the treatment there. I want to make sure we covered it. Okay, pancreatitis. This is inflammation in the pancreas. It can mimic that cholecystitis a little bit in presentation. So it's going to be a little bit difficult to differentiate. And that's why we might learn a little bit in our labs and also the history. I think of pancreatitis in a person who maybe had a little bit of an alcohol use disorder, maybe went on a binge, had a lot of alcohol over a short amount of time. Over the weekend, something bad happened and maybe they had a lot to drink. This can provoke something like a pancreatitis. Also, somebody with high triglycerides can provoke a pancreatitis. So, something that we need to be worried about. Do they have high triglycerides and somebody started a GLP-1 on this patient? If that's the case, it can evoke a pancreatitis. We read about that a lot in the literature. That's why we want to check our triglyceride levels before starting something like a GLP-1 medication for somebody who might have obesity or diabetes. All right. When we think of these guys coming in, we think of sharp upper left or that epigastric pain, typically worse after eating or drinking. Oftentimes, these guys are going to be feeling pretty bad, nausea, vomiting. Ugh, they don't look great. We can see signs that we should know about. So that colon sign is that umbilical bruising that happens right around here. And then we have that Grace, Turner, or flank bruising. Guys, any sort of bruising on the abdomen is always cause for concern. If you see bruising, you need to be asking more questions. Things that I think about domestic violence, I think about platelet counts and, clotting factors and things like pancreatitis. So these are not 100% for just a pancreatitis. However, it can be. But if you're seeing abdominal bruising without a good story, I always want ask more questions and be worried about it. All right. Um, Pancreatitis is a medical emergency. We're going to get these folks to the emergency department. The treatment is pretty interesting. It's just kind of resuscitation with lactated ringers. Okay, so they go to MPO, really rehydrate them, and usually that's about all they have to do. These folks take a little bit to start feeling better. Maybe they'll give them some anti-nausea, pain medication, stuff like that, to help them out. But they'll usually resolve on their own with that. And then we really need to talk about alcohol use disorder if that's what we think is going on. Things like naltrexone do help a lot to help reduce cravings and just like the pleasure from it. So don't stray away from those conversations if they come back to your primary care after you've sent them to an ER or something. Let's talk about what's going on if they're ready. Okay. So some of the diagnosing of a pancreatitis, we're going to get labs. You're going to draw a lipase or an amylase. You're going to see levels go up 2 to 3 times that upper limit of normal. Also, you could go ahead and get some imaging done. CT, MRI will also be done in an emergency room setting to go ahead and treat for that. All right, diverticulitis. Diverticulitis is inflammation. So here we can see our lower smegmoid colon here, the left lower quadrant I think of mostly when I think of diverticulitis. Okay, so what is it? We have these nice out pouches that happen in just with age. Not sure exactly why, but the bowel kind of has these out pouches. And then if we have a complication like a little bit of um, constipation occurring, what can happen is stool, we think, fecal matter, can actually kind of get entrapped into these out pouches and cause inflammation, and that can cause pain. And when we think of these things, as you can see, risk factors, age. So age just causes more of these bowel outpouching. Then we also think of low fiber diets or high fat diets tend to do this. And I think of that more in relationship to that constipation and maybe just slower movement of stool through that area. Obesity, smoking, and NSAID use all seem to be risk factors. These folks come in, they have abdominal tenderness, may have a palpable mass. So we do want to assess for that. Would be an abscess. We're going to hear hypoactive bowel sounds typically in these folks. We're concerned about one of these guys perforating and opening up. And when that happens, now we have fecal matter stool contents in our peritoneal cavity. Never a good thing, right? That's very, very at risk for something like shock. So when we think of shock, we think of hypotension, tachycardia, abdominal tenderness regarding rigidity. Those guys, hopefully this person's not in a primary care setting, but if you're working in an emergency room, you might see something like this. So it's important to know the signs and symptoms. We'll go ahead and get labs on these folks. We think of an elevated white count, elevated inflammation markers. A CT might show us some thickened bowel happening in that area, might show us an abscess. That has occurred. So we want to just be careful. We used to think that diverticulitis was caused by seeds and nuts and popcorn and stuff like that. That's no longer the thought. And so we no longer tell patients they need to avoid those types of foods. That's kind of new. We are changing our treatment around diverticulitis. We used to do antibiotics for everyone. Okay, that treatment is changing. We're learning more and more that maybe we can actually just go to like bowel rest. So something like fluid diet, depending on their state on how they present. If they are unstable, if they're fever, if they're sick, obviously we need to get them higher level of care and get them in right away. Right, like we see here, unstable patients, we're not dealing with them in the outpatient. However, if you have a patient who knows that they have this because they've done their routine colonoscopies, they've been told that they have diverticula, um, then and they present very in an early stage of diverticulitis, we can go ahead and we feel comfortable. Maybe they don't have fever or anything like that. They just kind of have some discomfort. We can treat their constipation, and we can get them on a on a fluid diet just for a little bit. But we want to reevaluate quickly. Okay, we're not going to just send these people out the door and never see them again. We'll probably reevaluate. I want to see them maybe in 2 days at the minimum. I think up to date says reevaluate within 3 days. And you can choose if you want to go ahead and add an antibiotic to that patient in an outpatient setting. That would not be incorrect. It's a shared decision making with your patient and how fast they can get in and what their ability is to get help if needed. Okay, appendicitis. I'm going to just tell you guys, we are over our time. You have, if you're still here, you have completed more than 80% of this lecture. You're going to get your credit. I'm happy to keep talking if you all want to stay. If you need to break away, feel free. I appreciate you coming. Okay, I do realize the time we have gone over here. So just want to let you know that. Okay, appendicitis. I think that appendicitis, you're going to see this. It's really common inflammation of that appendix. I think of, younger men, boys in particular, being at risk. So, this is. Just a quick story here. I had my son when he was like 9, had really bad right lower quadrant pain. After coming home from soccer, he came home and he was like, "Oh, I have this really bad pain in my right lower quadrant." Well, he didn't use those words, just right here. And so what do I do? I think right away appendicitis. So we're going ahead and doing these exam findings, these special techniques. There's lots of them, and looking for it. So I think of young men as the biggest risk factor. Obviously, it can happen in anybody. I had my friend while she was pregnant, she had to have an appendectomy. So it can occur in different people. But that's your most common patient that you're going to see is these younger men or boys. They're going to come in with, belly pain. It oftentimes will start in the umbilicus and transition over to that right lower quadrant pain. We'll see some nausea, vomiting, fevers, just don't feel very good, right? They have an infection occurring in their body for some reason. And then when we do some exams, we're going to look at that McBurney's point, which is right in this area right down here. And that's where we're going to be touching. And so we see guarding, we see anything like that. My kiddo, I'm thinking testicular torsion, I'm thinking appendicitis, blah, blah, blah. It was just a muscle strain. He was fine. We didn't have to do anything else. He didn't have any of these other positives. So we think of McBurney's, Bloomberg's, Rosvig's, all of these different things. I'm going to go ahead and put this slide up. Take a photo of this, practice it on your partners, practice it on yourselves, go through it. Make sure you know these different things for your boards exam. They're very helpful. But one thing that I love, and this is what I think I ended up doing with my son, is this Markle's test. This is so easy. You watch a kid walk across a room. If they're walking into your office and they are walking very carefully, maybe on their tiptoes, they don't want any jolting happening with that, just the movement of walking. I think that's kind of a telltale that there's some sort of peritoneal something going on. If they come to your office, hey, I have really bad abdominal pain, and they're walking and trying not to move. Oh, they are doing the Markle's test for you, which is just dropping the heel down. Okay. When we drop that heel down, it causes a lot of reverberation kind of up into that area. That the way the muscles kind of push and pull there, it's going to cause some pain on an infected appendix. And then we have all these other signs. So what do we do about it? Appendicitis it's an emergency because we're worried about perforation and then getting any sort of infected material into the peritoneal cavity. So at the emergency room, they may choose antibiotics and fluid and just observation, and they might, in more severe cases, or if there's a perforation, then surgery would definitely be warranted at that point. Okay. Next up, IBS. IBS is a really common thing. We think of females and stress as kind of being some of those really common risk factors. So, like a nursing student could present with some irritable bowel things. Again, it can happen in men, it can happen at any age. But typically, I think of a college age woman just going through a lot. Okay, that's your typical patient. Now, again, it can be anybody, so don't hold on to just those details. What happens with IBS is we don't quite know exactly what's going on. We're going to rule out anything kind of more severe, like an infection, an autoimmune disease, um, some of these more concerning thing. I mean, this is concerning, but we want to make sure that we're not missing something that we need to treat differently, right? Like an IBD or Crohn's or, inflammatory bowel disease type things. So what we see oftentimes when we're thinking about IBS is somebody who has this abdominal pain and bowel habit changes. We think of that Rome 4 criteria used in diagnosing. So it's a diagnosis of exclusion just a little bit here. So we're excluding everything else, and then we come back to this. So our Rome 4 criteria is recurrent abdominal pain at least 1 day a week, accompanied by two of the following. And these are going to happen over the course of about 3 months that we kind of see that it's chronic. It's kind of comes and goes, but it's been there for a while. So we could have pain in relation to defecation, a change in stool frequency, or the way the stool looks. So we can have diarrhea or constipation or going back and forth between those two things. All right. And that's going to be really indicative of how we're going to look at those criteria in the diagnosis of IBS after we've made sure there's nothing else going on. All right, so what do we do about it? I love the FODMAP diet. I don't keep people on a FODMAP diet by any means. What I do is I print out what is a FODMAP diet, what are those foods that we should kind of avoid, and then we're going to slowly reintroduce those foods. And anything that tends to cause your symptoms to flare up, let's see if we can live without it, and if that makes sense. We also do high fiber diets or laxatives depending on their presentation. So low pyramide. I also love probiotics. I'm a big believer in that microbiome, and I think we're just kind of unlocking that a little bit, but making sure that we have our microbiome in its most helpful state. So whether you take a probiotic or whether you're just really conscientious of making sure you're getting some of those fermented foods. It's really, really important, especially if folks were treated a lot for like ear infections as a kiddo and stuff like that. We want, this evidence is emerging. We don't have a huge wrap on it, but it is important in our conversation for folks. Again, we can avoid those foods that cause our symptoms, and we're gonna do some like really intense like food journaling. I know patients don't love hearing that, but if they feel better, they're gonna go for it. So let's go to this really bland diet and then reintroduce. Once we get symptoms totally under control, then we reintroduce our foods that oftentimes seem to be more provoking for IBS. Okay, IBD. Here we have an autoimmune disease occurring. For some reason, our immune system inappropriately is attacking our GI system. That is different from IBS because in IBS, we don't see this inflammatory elevation that we see in IBD. We see intestinal damage. So if we go in and we scope this patient, there is visual and um, tissue evidence of disease and destruction happening here. So Crohn's disease is really a manifestation of strictures, inflammation. We think of skip lesions, we think of fistulas occurring in the GI. The Crohn's disease can happen anywhere in the GI. And typically those patients are going to have abdominal pain. I'm going to say more generalized abdominal pain here, nausea, vomiting, weight loss, and non-bloody diarrhea. Okay. You can get it as CRP and just see if there's inflammation happening. If there's inflammation happening and they're having some of these other symptoms, we need to get them in for a scope right away and a diagnosis. So, an EGD or a colonoscopy to help with the diagnosis, depending where we think the symptoms are coming from. GI is going to help with all of that. Ulcerative colitis, on the other hand, this guy's happening in the and only in the colon, okay? And it typically starts in the rectum and works its way up. We can get these guys into a disease, remission, and that's our goal, all right? So it's probably always going to be underlying, but can we use some of our different treatment options to put them into it? Yes, we can. That's our goal here. With ulcerative colitis, here we see more of that bloody diarrhea. We see mucus. We see tenesmus. Tenesmus is that feeling that you need to empty your bowel after you've already emptied it. Like there's no more stool in there, but you're straining and straining and straining, and it feels like you need to keep pushing. All right. Really, something that we want to be on the lookout for is toxic megacolon. This is an emergency. We want to make sure that we're addressing it, getting them to emergency care right away. Sorry, when we think of autoimmune diseases, we think of family history a lot. This tends to be somewhat genetic, and it might be a different type of autoimmune disease, but we do think of autoimmune diseases and asking about their family history here. Stress, maybe a viral exposure can turn this on. So maybe they have the genetic kind of underlying genes, but the gene is shut off, and then they have this. This is what we think might be happening, that a virus actually comes in and turns on this gene to be expressed as an autoimmune kind of issue. We don't know for sure. That's just a theory. However, when we're diagnosing it, again, history, we're going to look for any signs of inflammation. And then we're going to confirm with a scope and a biopsy. All right, so we'll see those changes happening in the tissue. And depending on where it's at and what else we're seeing, the diagnosis of IB, IB ulcerative colitis versus Crohn's disease. So IBD is kind of that class, and these two are the most common diseases that fall under that class of stuff. Okay, I am going to, do you guys prefer, you can put in the chat, I can talk about hepatitis or do the case study. Which do you prefer? Any thoughts here? Case study. Okay, let's dive in. Let's do the case study here. Okay. Okay, we have a 62-year-old male patient, hypertension, obesity, hyperlipidemia, prediabetes, current medications. Current medications are lisinopril, hydrochlorothiazide, semaglutide, rosuvastatin. Left lower quadrant pain onset, 8 out of 10, pretty constant. He's using some ibuprofen without much relief. He's got a fever, 101. Here's his blood pressure. We have some abdominal rigidity, hypoactive bowel sounds in that left lower quadrant, and associated things, nausea and constipation. All right, let's go to Slido, and I want to hear anything on your differential. There is, okay, 1 second. Anything on your differential that's here. There is no bad answers, things that just anything that's coming to mind. This is just like this, like, okay, what could possibly be happening? Diverticulitis. What else? Um, let's go here. I'll just show you the case study again. So he's got hypertension, obesity, hyperlipidemia, left lower onset, constant, ibuprofen. Yeah, seems like not a bunch. A little bit of rigidity. Anything else on your IBD? Good, 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 good. Love it. Just differentials, anything that comes to mind. Constipation. All right. And what labs, imaging would you consider ordering for this patient? Just any diagnostics that might come to mind. CT scan, love it. Yep, CRP, ESR, you're looking for inflammation. What else? What about a white count? How would we get a white count? What about liver, lipase, love it. So we're looking at that's pancreatic. Yep, CBC, we're looking for those whites. See if there's any elevation there. Maybe an ultrasound, depending on if there's an insurance issue. Amylis, like it. LFTs, absolutely. Good, you guys. Maybe a CMP, we could get renal and LFTs in that. I would consider hemoglobin. Okay. Looking for some possible bleeding. Great. All of those things are really good. Yep, CMP. Wonderful. Awesome. Okay. Let's keep going. Okay, so you order these things here. Differential diagnosis, just some things that came to my mind. Diverticulitis, that was number one. IBS, IBD, colorectal cancer, appendicitis, bowel obstruction, pancreatitis, ischemic colitis, nephrolithiasis. That's why I wanted that renal function just to see. Also, maybe getting a KUB, like making sure those kidneys don't have a bunch of water backed up in there if you were to think about a kidney stone. Okay. But I think what everybody said was great. CBC, the things that I would order, CBC, CMP, CRP or ESR, amylase lipase, also getting a CT, ultrasound or MRI, some imaging, maybe an X-ray. Okay, what we saw here is that his white count came back at 11,000, so he's got an elevated count, localized bowel wall, just some thickening, some inflammation, presence of diverticula, no abscess, no perforation. Okay, this is important. Okay, this is important because we think of our indications for admission. Does this patient need to be inpatient or does this patient need to be outpatient? I got this from Up to Date, guys, and this just kind of goes through and says, based on how he's doing, should we put him in or out of the hospital? We are going to diagnose him with an uncomplicated diverticulitis. Okay, we can go ahead and do some pain management for him. If we want to keep him on that outpatient or inpatient, you guys get to decide. Liquid diet, 5 to 7 days, and then reevaluate and advance to soft and then regular diet. So you go very slowly on that. Antibiotics, like we talked about, not always. So if he had major comorbidities, if he's immunocompromised, or if he's taking any immunologics, we would definitely do antibiotics for him. Okay. If we had some systemic disturbance here, he did have a pretty elevated fever, a pretty elevated white count. I might consider a little bit of a Moxclov for him. I would maybe avoid the fluoroquinolones just because of that risk of tendinopathy with it, and then rest and hydration. Okay, we're gonna follow this guy up very soon. I would get him back into clinic, in like 2 days, and maybe call the next day just to see how he's doing. If I did do an outpatient follow up, just I tend to be much more conservative with my patients and really. Whew, don't want to cause any harm. Reevaluate within 1 week is what Up to Date says. A high fiber diet, and then avoid any of these things. We talked about weight loss, and then we're going to get a colonoscopy 6 to 8 weeks after the resolution of symptoms because we want to rule out any sort of malignancy happening there. Okay. Um, and then we can refer to GI, right? So we could have referred right away. We can kind of hold off and make that decision. Again, shared patient decision making always going to kind of lead our guidance on what we do. All right, we've wrapped it all up. I have a few more questions if you can. Sorry. Okay. How confident, after today's webinar, this is just a confidence test that we need for ANCC. How confident do you feel in your ability to perform some of these special exam techniques for abdominal complaints? So 1 is no confidence, 2 is not very confident, 3 is somewhat confident, and 4 is very confident. So after today, did you learn anything? Do you feel a little bit better about some of these techniques that we can do? So we talked about, looking for appendicitis. We talked about the Murphy sign. 3, yeah, and that's kind of where I hope you would be. That's great. Awesome. I think we're losing lots of people here. So, guys, it was such a pleasure. I'll be back in 2 weeks. We'll be talking about musculoskeletal system. If you have any questions, you can reach us. Let me just snag over to our email here. Please, feedback. We're always open to new feedback, suggestions. And please, please, please just reach out to us at nursepractitioners@archerreview.com. Again, guys, this SurePass Pro package, I wish I had it when I was studying for my boards. I would have done it in a heartbeat. Price is right. And I think being really confident walking into that exam just makes all the difference for your day to day. I have 2 more minutes if anybody has any pressing questions that they want to review. We talked about a lot of stuff today, so I am more than happy to go over anything that you have. If you have any questions, I'll hang around here for just a couple more minutes. But you guys did so good. You're going to do great on your exams if you haven't already. All right. Um, Childhood peds conditions. Okay, so that's like a suggestion, Anna. There's an in the QA. Oh, Angela has a question. Yeah, go ahead. Oh, the encoparesis with stools. Encoparesis. Yeah. Let me type it. Encoparesis. I believe that. Let me just double check the spelling on that real quick. I think it's ENO. Encoparesis. I just want to make sure I spell it right when I tell you guys. Encoparesis. Encopresis. Yeah. Okay. Encopresis. Okay. So encopresis is can be caused by a lot of things, but I think about kiddos. Electron hepatitis only. Yeah, that would be great. Especially the testing stuff. The labs that we get on hepatitis, super important. Encopresis is basically when there is like in the large intestine in that descending colon, there is kind of a backup of stool. And the reason that this can happen is typically multiple factors. So if a kiddo is not getting a lot of fiber in their diet, they can also have um, just like slow movement of their bowels. If they're dehydrated and they don't have a lot of fiber in their diet, then they get these stools that can be very bulky. And then try to pass that stool, what can happen is there can become anal fissures. So just little cracks and yeah. What's the word? Like cuts basically around the rectum. And so when they pass a stool, it burns and it hurts really bad. What that can cause is if they have an unpleasant experience evacuating their bowel, that can lead them to be fearful of evacuating their bowel. Or perhaps one of my kiddos, he went to a preschool where they had to leave the door open in order to go to the bathroom. And so what he would do was hold his stool because he could not go to the bathroom, which I don't understand the reasoning behind that. Probably there was some point with some good intentions at somewhere. But this kiddo had severe, severe trauma, and he would hold his stool. Then he would pass large stools. When he couldn't hold it any longer, he actually plugged some toilets. So then it became a behavioral thing. Right now, he's embarrassed to use the restroom. And then what would happen is when you have this big blockage of stool and you've got all of your mental wherewithal to hold it in, but what happens is you get this kind of dilation in that lower um, colon, and then stool needs to evacuate. So then you get sludge that comes out. So what you would see, like in this kiddo, we would just see little bits of stool in his underwear. Sometimes on his rectum, you would see just really sludgy, thick stool that would get kind of stuck. And it's just oozing around that mass of stool inside. And so what we do for those kiddos is a clean out. And so this was during my residency when I worked with a pediatrician, and we did a full, like over the weekend, very intense bowel evacuation regimen that the parents did at home. So we did Senna and Docusate and then Miralax and just got this kiddo to the point. And the stool is going to change colors because we have like a backup of stool. So just tell the parents it's going to become like a dark color if you're clearing some of that stuff out. It's not blood, it's just the change in the stool. But you do a full clean out and then you keep them on a Miralax daily until that behavior starts to change. For this kiddo, months and months and months to try to get him more to feel better about about stooling, and then we did scheduled stools. So he would not go to school with, like he would wake up a little bit early, sit on the toilet, make it a pleasant experience, reading a book, mom, like, and give him the privacy that he needed. All of those things really, really important. He was 5, to kind of return the pleasure of having a bowel movement and taking away that fear and that shame and all the things that came for this poor kiddo. But you'll see that in different ways. And then, we can have slow digestion for different reasons, different medications, different conditions. So things to be on the lookout for. It can be behavioral, it cannot. So, make sure you're asking the right questions and kind of understanding this. It took the kiddo, the mom had no idea that they had to use the bathroom with the door open. He told me that. I said, like, what's scary about going to the bathroom at school? And a question she had never asked in those terms, right? She's asked, I'm sure, a million questions to the kiddo. And when I asked that, he said, well, I have to keep the bathroom door open and I don't like to do that. There was a conversation also with the teachers. Hey, can we please close the bathroom for, he needs to close the bathroom door. As probably most of the other kids prefer that, but yeah, maybe you can be on the outside and just listening in and making sure that there's nothing crazy happening in the inside. But kiddos at that age typically do okay. Okay. It's a pleasure, as always, guys. I will see you all back in 2 weeks. Okay. But we have lots of other stuff coming up. So just watch us, follow us, and like us on our social medias so that we can get this out there to everybody else. All right. Take care.